Early recognition and early intervention is essential for saving lives. Moving ahead, I request Dr. Shalin to tell us how to assess the collapse victim.
Good morning, all the respected dignitaries, Dean Sir, MS Sir, Vice Dean, Dean Academics, Ravante Sir, and MD Sir. So we will be proceeding towards the primary survey of the patient. So when we find a patient unresponsive in out of care scenario, out of hospital scenario, like on the roadside or at home, which comprises maximum percentage of unresponsive patient, which are found mainly in the home, and they do not get a proper resuscitation, which leads to ultimately cardiac arrest. So the primary survey of an unresponsive patient includes to verify the scene safety. So first of all, when we reach the scene of an unresponsive patient, we have to ensure that the area in which that patient is, it should be safe for the patient as well as for the rescuer. Second is to check the response. Then we have to call for help. Then we have to activate the emergency system, which is 108 in our state, and then check for breathing and pulse, and then we have to start CPR. So we will go slowly and we'll understand each step one by one. So in this slide, as you can see that there are certain scenarios where scene is not safe. Like if we get a patient drowning in a swimming pool, we cannot just jump into the swimming pool and start the resuscitation. Similarly, the places where incidents of fire happens, then first we have to move the patient to a safer place and then we will start the resuscitation efforts. It will ensure the personal safety of the rescuer, then safety of the colleagues, the team, and the safety of patient as well. So how we will check the response? There is a certain guideline that we have to check the response properly, and we do not have to overdo it. So we can do it by gently tapping the shoulder and to ask, hello, are you awake? या भाई साहब आप ठीक हो कि नहीं? Why it is so? It is so because if you will exaggerate such kind of movement, then there might be a possibility of underlying cervical injury. If we will exaggerate this movement, it will lead to further injury to the cervical spine. So shake the shoulders gently, ask, are you alright? If he responds, then we have to leave as we find him, or then and find out what is wrong and reassess regularly. So now there are two kind of situations which can arise. If we will tap the shoulder and the patient responds, then it is okay. The respiratory movements are normal and the patient is responding. It means we don't have to do anything for this patient. But if the patient is not responding properly, then we have to proceed for next step. Then if we find the patient unresponsive, then we don't have to jump to the patient. First we have to shout for help. If anybody crossing by, or if you can get an help of some other person, it will be of great help to the patient at the time of CPR. So first we have to find any kind of help which is present at the scenario. Then activating the EMS. Sanjeevani 108 is the emergency medical ambulance service which is running across the state of Madhya Pradesh. So we have to notify them, and while notification, what are the things which we have to take care in telling that EMS system. So we have to tell the number of patients or number of unresponsive patients which are present at that proper place, and then we have to properly tell the address, because if you will not tell the address, it will the ambulance person will get confused, and it will delay the commence of the service of EMS to the site. So number of patient who are unresponsive, then proper address should be told in detail to the EMS system. Then now we will go for the survey of the patient. Then we have to check the breathing as well as pulse. So first we look for the breathing which can be normal or agonal. Do not confuse agonal breathing with normal breathing, which can be recognized as a sign of cardiac arrest. And simultaneously we check pulse of the patient. Now this is very important. What AHS suggests that both these steps should be done within 10 seconds only. Why? Because if we will delay assessing this for more than 10 seconds, then the result of your CPR cannot be that good. Because if the interruptions are more than 60% of the overall rescue time, more than 60%, which is called as the fraction of cardiopulmonary resuscitation. This fraction should not be less than 60%. If it is more than 60%, then the survival rate of the patient increases. But if the interruptions are more than 60% of the total time, then the survival rates are very less. Secondly, when we provide CPR to the patient, the perfusion of the end organ continues more properly when we will minimize the interruptions. When we interrupt a CPR, the perfusion to the organ compromises, and when we restart it, then the time taken to reperfuse those organs is further more. So we have to take care that the interruption should be very less, and an ideal CPR should have 80% of the fraction of their performance. So first we have to look for the carotid pulse. For this we have to only palpate one carotid at a time, and it can be medicos will know, but as we are having a lot of other systems also, so we have just to slide our finger from the midline, and we have to palpate a groove which will be between the thyroid and sternocleidomastoid, and in that groove we will easily find carotid. What if we find a burn patient who is having an upper body burn, and you cannot palpate carotid? Then in such situations you can opt for femoral pulse also. Now, what about lay rescuer? A lay rescuer who is not trained, he cannot check for such kind of pulse. So healthcare provider should not take more than 10 seconds for pulse check. So if a person is lay and he could not check, then he should straight away go for CPR. So how we will perform a high quality CPR? We have to follow CAB, which is compression, airway and breathing. The CPR ratio should be 30:2, which is 30 compressions and 2 breaths. So now there are some things which we have to take care while chest compression. The patient positioning. Patient should be lying on the firm and flat surface. Why it is so? Because in ICU setup we find air beds, water beds, etc., which have lot of cushion. So it will not transfer the force which you are giving on the for CPR to the target organ, which is heart. So we have to deflate the air and water matrices, and then reservoir position. The reservoir should be at the level of the patient, elbows vertically and straight and long. Shoulders directly above the hand and heel of the palm over the other. So at the time of CPR, what I have seen that most of the people just stand by the side of the patient, but the weight of the body doesn't transfer to the patient. So we have to just make our shoulder just above the heart level, and then we have to start the CPR with straight elbows. We should not bend our elbows. Now, where we should keep our hand? The hand should be at the lower shaft of the sternum. Then we have to push hard and push fast, and depth should be at least 2 inches, but not more than 2.4 inches. Why it is so? Why should not we कर देते हैं ना compress और अच्छा खूब सारा जाएगा? नहीं, it should not be like that because it may injure other, it may cause injury. Over exaggerating the depth of compression could lead to injuries like it can patient may land up into fractures of the rib etc. and the other thoracic injuries. Then rate should be 100 to 120 per minute, and the ratio should be 30:2. Allow the complete chest recoil because the chest recoil creates a negative intrathoracic pressure which ultimately draws air into the thoracic cavity. So we have to allow chest recoil. Minimum interruption within the compression. I think I have told it in detail. So
Thank you so much, Shalin sir. As sir has very rightly said about whenever you are starting with the BLS, what you need to do is first you need to assess the scene safety. Whether you are first you should see your safety, your colleague safety, and then the person who is unresponsive should see his safety. So if there is a fire, if there is water, drowning chances are there, you should assess your safety first and then you should approach the person. Second thing, what you have to do is you have to check for the response. By tapping the shoulder, you can assess whether the patient is responsive or not. After assessing the response, what we need to do is if the patient is unresponsive, we need to shout for help. After shouting for help, we need to activate the emergency medical system, which we can do with 112 or 108. After that, we will go ahead by checking the breathing and pulse, and that has to be done simultaneously. While you are checking for breathing, simultaneously assess for the carotid. In kids, we don't assess carotid, we go for the brachial. And another thing, after we see that there is no breathing, no pulse, we should immediately start with the CPR, that is chest compression. So now I request Dr. Arvind to tell us in detail about how we should give the chest compression, how to manage the airway, and how we should go ahead with the breathing management. Thank you.
Thank you, ma'am. Good morning, everyone. Respected dignitaries and all the members present here. Why we need chest compression for the CPR? Chest compression acts as the systole and the recoil acts as the diastole. So the thing is to maintain the blood flow, we are working as artificial heart. Okay, so that's the thing we have, as sir told correctly, the chest compression should be not be overdone and underdone. Okay, so it should be 2 inches, at least 2 inches, not more than 2.4 as per the AHA guidelines, and rate should be 100 to 120 per minute. And allow chest recoil because there should be the, as sir told, there should be a negative intrathoracic pressure which acts as the diastole. So the, whatever the blood has, while you have attended the chest compression, allow the chest recoil, but not it should not be overdone and underdone, and minimum interruption between the compression. How airway? Airway is a major backbone of the CPR, because without a airway you can't your CPR might have is incomplete. And how we provide the airway? Airway as this is the position of the airway for the normal person who have not suffered the cervical injury. In case of the cervical injury, you can't do head till chin lift maneuver, but in case of cervical injury, we should provide the jaw thrust, because there is a major major nerve supply from the cervical region is from C1 to C4, and this is a breathing procedure where 30:2 should be provided as a good CPR. Oh, thank you.
On the recovery position. In case where breathing is normal and you want to put the patient in the recovery position, so you can explain well about the recovery position.
Now, positioning the patient after resuscitation, and as we know that when patient is recovered, his higher mental functions cannot be very normal, and the bulbar part of the brain, which includes the airway reflexes, it should not be intact, may not be intact, may or may not. So we have to ensure that due to this altered sensorium, patient may not aspirate the contents which is present in the mouth. So for allowing the patient to maintain a healthy respiration without any kind of aspiration, we position the patient in a particular way, and this is called a recovery position. So how it is done? As you can say, one of the hand is kept below the face, and you can notice the mouth is directed downwards, so that any kind of secretion or any kind of oral content dribbles down to the ground only, and it should not remain in the mouth, or it has lesser possibility of going into the pharynx and further to larynx and trachea. So just to avoid any kind of aspiration or aspiration pneumonitis, we have to position this patient very properly.
Thank you, sir. So whenever we see that we have got a return of a spontaneous circulation, that now your CPR is effective, patient is breathing normally, or while we were assessing the patient initially, the patient was having normal breath and normal pulse. So what till the emergency medical services arrive, we need to put the patient in the recovery position. This is to do two things. One, sir has correctly mentioned that to prevent the aspiration. Second is to prevent the injury, because the patient is unconscious. The patient may roll down, which may increase his injury. So what we do is, we do his first hand at right angle. Doing that, after that we will put another hand on his cheek. And now we will turn the patient to one side and will turn his neck to 90 degrees. This is called a recovery position. This is to prevent the injury and to prevent the aspiration. Now moving ahead, I request Dr. Ankush to highlight what are the key differences in BLS for infants and children, which differentiate it from the adults.
Good morning to all of you, and warm welcome and gratitude to all seniors and respected dean sir, MS sir, and director sir. I want to we have to know first कि जब भी चिल्ड्रन चाइल्ड एज ग्रुप में रिसब्सिटेशन की बात करते हैं तो अपन डिफरेंटली उसको 3-4 कैटेगरी में डिवाइड करते हैं। एक होता है अपना नियोनेट। नियोनेट क्या होता है? न्यू बोर्न टू अप टू 28 डेज ऑफ लाइफ का जो बच्चा होगा वो नियोनेट कहलाएगा। वो नियोनेटल रिसब्सिटेशन is slightly different from adult or infant and children resuscitation. We will discuss later on it. And फिर infant age group आता है। infant age group lies between 29 days of life से 1 year of life, मतलब बेबी अपना 1 month to 1 year के बीच का है तो उसको अपन क्या बोलते हैं? infant। उसके बाद अपन और डिवाइड करते हैं 1 to 8 year स्मॉलर चिल्ड्रन एंड 8 year एंड अब वो लगभग एडल्ट जैसा हो जाता है। तो थोड़ा डिफरेंसेस रहता है कि इन्फेंट की बात करें, नियोनेटल रिसब्सिटेशन की जब अलग वर्कशॉप होगी उसमें बात करेंगे, वो थोड़ा डिफरेंट है इस रिसब्सिटेशन प्रोग्राम से। तो इन्फेंट रिसब्सिटेशन का जो डिफरेंस है अडल्ट रिसब्सिटेशन और बिगर चिल्ड्रन के रिसब्सिटेशन से, वो भी डिस्कस करेंगे अपन। उसके कुछ पॉइंट्स हैं, जैसे कि पहले बताया कि जो रिस्पॉन्स चेक करने के लिए नॉर्मल टेपिंग ऑफ शोल्डर और शेकिंग ऑफ शोल्डर करते हैं इन अडल्ट और बिगर चिल्ड्रन में। वाइल इन केस ऑफ इन्फेंट जो कि 1 ईयर से कम के बच्चे हैं उनमें वी डू जेंटल और फ्लेकिंग और टेपिंग ऑफ सोल। सोल पे फ्लिक करेंगे या टेप करके देखेंगे टू इन ऑर्डर टू चेक स्टिमुलस, इन ऑर्डर टू चेक रिस्पॉन्सिवनेस। एक पॉइंट तो ये है, बिकॉज क्या है कि इन्फेंट जो रहते हैं वो बहुत मिनिएचर होते हैं। वो सेकेंड थिंग, असेसमेंट ऑफ पल्स में अडल्ट और बिगर चिल्ड्रन में हम लोग नॉर्मली कैरोटिड यूज करते हैं, और अगर 1 पेशेंट है या कैरोटिड असेसेबल नहीं है तो वी विल यूज फीमोरल पल्स। वाइल इन केस ऑफ इन्फेंट, बिकॉज इन्फेंट में शॉर्ट नेक होती है और चिन फेट भी रहता है, तो इट इज डिफिकल्ट टू असेस कैरोटिड। और कैरोटिड को अगर ज़्यादा प्रेस हो गया तो न्यूरोलॉजिकल प्रॉब्लम भी हो सकती है उससे, कि जो ब्रेन में ब्लड का सर्कुलेशन है वो कंप्रोमाइज होता है। तो हम इन्फेंट में क्या करते हैं कि ब्रेकियल पल्स पाल्पेट करते हैं। नॉर्मली कोई 10 सेकेंड के लिए ब्रेकियल पल्स पाल्पेट करेंगे तो 2 पॉइंट ये होगा, एक तो टेपिंग ऑफ सोल करेंगे और सेकेंड पॉइंट है अपना, सेकेंड थिंग इज जो पल्स के असेसमेंट के लिए ब्रेकियल पल्स को 10 सेकेंड के लिए पाल्पेट करके देखेंगे। कुछ पॉइंट्स अलग भी हैं, जैसे कि नॉर्मल अडल्ट और बिगर चिल्ड्रन में हम लोग क्या करते हैं कि जो चेस्ट कंप्रेशन देते हैं उसके लिए हील ऑफ हैंड, वन हैंड को दूसरे हैंड पे ओवरलैप करके उसके द्वारा प्रेशर सबमिट करते हैं। वाइल इन केस ऑफ इन्फेंट अगर सिंगल रेस्क्यूअर है तो वी विल यूज 2 फिंगर टेक्निक। क्या करेंगे अपन, जो अपनी इंडेक्स फिंगर और मिडिल फिंगर है उसको परपेंडिकुलर लोअर 1/3 ऑफ स्टर्नम में रखेंगे और उससे चेस्ट कंप्रेशन देंगे। नॉर्मली अपन 90 to 120 इवेंट्स, 90 to 120 चेस्ट कंप्रेशन इन 1 मिनट में देते हैं, और उसका रेशो जो रहेगा वो 13:2 रहेगा, मतलब 30 चेस्ट कंप्रेशन और 2 रेस्क्यू ब्रीथिंग। अगर 2 रेस्क्यूअर अवेलेबल हैं तो वी विल यूज 2 थंब हैंड इनसर्कलिंग टेक्निक। इसमें क्या करते हैं कि दोनों फिंगर से पूरा जो चेस्ट इन्फेंट का होता है वो इनसर्कल करते हैं और दोनों थंब को अप्रॉक्सीमेट लोअर थर्ड ऑफ स्टर्नम पे प्रेस करके उसको चेस्ट कंप्रेशन देते हैं। तो ये दिस मेथड इज बेटर देन 2 फिंगर टेक्निक, बिकॉज इसमें प्रॉपर चेस्ट इनसर्कलिंग होती है, प्रॉपर प्रेशर ट्रांसमिट होता है और कोरोनरी परफ्यूजन और हार्ट परफ्यूजन बेटर होता है। तो ये 2 फिंगर हैंड 2 थंब हैंड सर्कलिंग टेक्निक इज एप्लीकेबल फॉर 2 रेस्क्यूअर एंड इट इज बेटर देन 2 finger technique. So these are differences.
Thank you, Ankush. Just highlighting what he said, that for assessing the pulse, we have to go for brachial in kids rather than going for carotid. For tapping, we need to do the sole flickering rather than going for the shoulder tapping. Third thing is ratio is different. When single rescuer is there in children and when you are doing the 2 finger technique, then 30 compression has to be given and 2 rescue breaths. That is similar to adults. But when 2 rescuer are there, one more colleague is there to rescue the child. When 2 rescuer are there, one will give the 15 compression and the another person will give the 2 breaths. So ratio in 2 rescuer in kids will become 15:2. Reason behind is adults में maximum कार्डियक अरेस्ट का कॉज कार्डियक रीजन से होता है, बच्चों में कार्डियक अरेस्ट का मेन रीजन रेस्पिरेटरी कॉज होता है, तो वी विल प्रेफर टू गिव मोर ब्रेथ्स एज कंपेयर टू compression. Now, this is just one situation we saw in infants and children how BLS is different. We have another special situation in which case if there is a pregnant woman who undergoes a cardiac arrest, so how BLS should be modified. So I request Dr. Jaya to highlight how we should resuscitate a pregnant woman.
Thank you, Dr. Priya. Good afternoon, everyone. Good morning, everyone. We are having a special situation that we are having a pregnant woman. In case of pregnancy, there is a gravid uterus which compresses the aorta and also the inferior vena cava, so that the blood supply and the level of hypoxia is more prone in the pregnant patient as compared to the non-pregnant person. So in case of pregnancy more than 24 weeks, generally gravid uterus compresses the inferior vena cava and aorta, so that we will always advise a pregnant woman to lie down on a left lateral position, so the aortocaval compression is less as compared to other situation. If we will start the CPR without doing the patient positioning, so our CPR will not be very much successful in that condition. So there are one single hand and second hand two-handed technique are there. As you see in the pictures, we will place the pregnant woman on a hard surface, and then we will lift the gravid uterus on left side, so that patient placed in the left lateral position. As Salish sir mentioned in the previous slide, that there is a role of perfusion of organ is very important in case of CPR. So if we will not do this step, our CPR will not be successful. So we should place the pregnant patient in the left lateral position, then we release the compression and will start CPR. And this should take at least 2 to 3 seconds just, but it will improve the quality. Second, as we mentioned, the hypoxia is very common. So first we will position the patient and start the CPR, and along with that it is very important the high flow of oxygen in that patient, because there is hemodilution of the blood in the pregnancy, and also there is a 2%, first is mother and second is baby is involved, so that we have to maintain the oxygenation to the patient, because if patient will go into the hypoxia, then placental perfusion should decrease and that will affect the baby. So we will try to save mother and fetus both, but our priority is to save the mother first, because if the organ perfusion is best, then mother will be saved, and mother will be saved, so there is a high chances of saving the fetus also. So we have to maintain the oxygenation simultaneously to the CPR. Fetal monitoring is not to be taken as emergency. We have to resuscitate the mother. जैसे हम सुनते हैं कि पहले माँ को बचाएं या बच्चे को, ये confusion हमें कभी नहीं होना चाहिए. We should save the mother first, क्योंकि mother के organ perfusion अच्छे होंगे, placental perfusion अच्छा होगा, तो fetus के survive करने के chances बहुत ज़्यादा होंगे. तो we should save the mother first. We will not engage in the monitoring of fetus कि हम डॉपलर लेके ढूंढ रहे हैं तो हमारे 10 मिनट उसी में खराब हो जाएंगे. तो हमें मदर का CPR, ऑक्सीजनेशन, एयरवे, हमारे पास यदि एम्बुलेंस हो गई है या हॉस्पिटल में है तो IV लाइन सिक्योर करेंगे, हम सॉल्यूशंस देंगे, शॉक से रिकवरी करेंगे. साइमल्टेनियसली हम अदर कॉजेज ऑफ शॉक और रिससिटेशन इवेलुएट करेंगे. ज़रूरी नहीं है हमेशा हर पेशेंट को कार्डियक अरेस्ट या शॉक इस कंडीशन में हो कि वो प्रेग्नेंट है. इसीलिए हमें और जो दूसरे कॉजेज़, मेडिकल कॉजेज़ होते हैं, प्रेगनेंसी रिलेटेड ऑब्स्टेट्रिक कॉम्प्लिकेशंस होती हैं, हमें वो भी रूल आउट करना है और उन्हें भी साइमल्टेनियसली डायग्नोज करके ट्रीट करना है. रिस्क असेसमेंट हम करेंगे पेशेंट की विद इन 5 मिनट, यदि हमारा पेशेंट रिवाइव नहीं होता है सब कुछ करने के बाद, तो फिर शुरू से देखेंगे कि हमें ऐसा तो नहीं, जैसे इन इक्लेम्शिया पेशेंट में वी हैव टू टेक आउट द बेबी फर्स्ट, then only patient will recover. So there is such conditions in obstetrics, we have to maintain that condition on an emergency basis also for saving the patient. So in case of pregnant women, firstly we will place the patient on a surface, then we'll give the left lateral position to the patient and start the oxygenation along with the CPR. Then maintain the IV line, crystalloid and colloid fluid should be given. Maintain the circulation and perfusion both to the patient. And all these are very necessary for the pregnant women. Thank you.
Thank you so much, Jaya ma'am. Now moving ahead, we have another thing. Now this is a key link in making a survival to the patient. So we need to see how to operate an automated external defibrillator. So I request Abhinay sir to highlight how to use a AED and how to apply the pads while using the AED.
Thank you so much, ma'am. Good morning to respective dignitaries, panelists, and audience. We will discuss on how to operate an automated external defibrillator